All right, so hi everyone, my name is Dana Wilkos. I'm the health literacy educator for the New Orleans Public Library. I'd like to welcome you all to the first program in our Research Matters series, All Health is Not Created Equal. It's in partnership with Tulane University's School of Public Health and Tropical Medicine, LSU New Orleans School of Medicine, and the All of Us research program. And forgot to share my screen, there we go. All right. Okay, so I do want to thank our partners for coming to join us today, as well as all of you for being here. I would like for you to check out nolalibrary.org for more virtual programming and resources. And if you're here in New Orleans, you can find out how to sign up for 45-minute in-person library sessions at a branch near you. A couple of quick housekeeping notes before we get started. First, we are recording today's event, as I mentioned. You'll notice we have everyone muted. I'd ask that you leave your mics off until we get to the Q&A session or section of the presentation. If you have any questions, please feel free to put them in the chat and we will get to those at the end. I also recommend turning on speaker view if you haven't already. We'll be sharing screens throughout most of it, but when we're not, you'll just, I think, find that to be the most helpful view to have on Zoom. And then I will be posting a link to a brief survey at the end of this presentation, so I kindly ask you to take a few minutes to fill that out. This series is brought to you by, in part by the network of the National Library of Medicine, which is the core of the National Library of Medicine's Community Engagement Program and has 8 regional medical libraries and over 7,000 network members. The mission of the network is to advance the progress of medicine and improve public health. And it supports its mission through the regional medical libraries by providing funding, training, and connections to empower members to transform their communities with trusted health information. They aim to improve the public's access to information with the goal of empowering people to make informed decisions about their health. The National Library of Medicine and the National Institute of Health's All of Us research program have teamed up to build the NNLM All of Us Community Engagement Network, and an All of Us Training and Education Center. The All of Us research program aims to build one of the largest, most diverse data sets of its kind for health research, with 1 million or more volunteers nationwide who will sign up to share their information over time. The Community Engagement Network is part of a pilot project and focuses on NNLM's mission to improve the public's access to information to enable them to make informed decisions about their health by partnering with public libraries across the United States, including the New Orleans Public Library. We will be talking more about the importance of medical research and the All of Us research project specifically in the coming sessions, so please be sure to join us for those programs in the next couple weeks. For more information about All of Us, please go to joinallofus.org/NLM. I will put that link in the chat. I do want to make sure we have plenty of time to get to our speakers, as they have a lot of great information for you all today. And I want to make sure we have lots of time for Q&A as well. So with that, I'm going to go ahead and introduce today's speakers. Our first speaker, Danielle Broussard, is an assistant professor in the Department of Global Community Health and Behavioral Sciences at Tulane University's School of Public Health and Tropical Medicine. She is a New Orleans native and graduated from Emory University in Atlanta and the University of Miami in Miami, Florida. Her research is focused on health disparities among women and children, as well as how to reduce health disparities. Our second speaker, Dr. Lucio Miele, completed his medical training in Italy and his research training at the Max Planck Institute for Molecular Genetics in Berlin. He currently serves as the head of the Department of Genetics at the LSU School of Medicine, where he performs research on breast cancer, and as Assistant Dean for Translational Research at LSU Health Sciences Center in New Orleans. Dr. Miele is also the principal investigator for the All of Us research program at LSU Health Sciences Center. Drs. Miele and Broussard, thank you so much for joining us. And Dr. Broussard, I'm going to go ahead and turn it over to you.
Great, and thank you so much, Dana. I'm just trying to share my screen now. Let's see. Let's see, okay, here we go. Okay. Okay, great. All right, so thanks again for the introduction. And I just want to say I'm really pleased to have the opportunity today to talk about what health disparities are. Health disparities are an important topic in healthcare and in public health, but they're also important for everyone in the community to understand what health disparities are, because they exist for so many groups of people within our society. So what I'm going to do today first is explain what a health disparity is. I'll follow that by providing a couple of examples of health disparities, and I'll talk about what causes health disparities. So first, what is a disparity? Well, the simplest way to look at a disparity is that it's a difference between groups. It's more complicated than that, but that's the simplest way to begin looking at disparities. So if we're talking about a health disparity, when we look at a health outcome for two or more groups and we see differences in this health outcome across those groups, then that's what we call a health disparity. So here's an example of a health disparity. And this graph is showing how common obesity is for 4 different racial and ethnic groups here in the state of Louisiana. So obesity, just quickly, is a way of telling whether someone is a healthy body weight for their height. So the amount of obesity in each group here is represented by the height of these colored bars. And you'll see that the red bar is for African Americans, the green bar is for Native American or indigenous people, the white Americans are represented by the blue bar, and Hispanics are represented by the yellow bar. So, so we're looking at the height of the bars to tell us how frequent obesity occurs in each one of these groups. And above that, you see a percentage, which explains the percentage of people within that group who experience obesity in the state. So you can see that the tallest bar is for Black or African Americans. And what we're seeing is that 46% of Black or African Americans in the state of Louisiana are considered to be obese. And that's followed by the next tallest bar, which is for Native Americans or indigenous people. So 41% of individuals within that racial group experience obesity. For white Americans, we see 33% and Hispanics 30%. And so we're seeing not as much a difference between the white Americans and the Hispanic Americans, but we're seeing this considerable difference between Black and African Americans and Native Americans when compared with white Americans and Hispanics. So this difference is what we refer to as a disparity, a health disparity. So I'm going to show one more example of a health disparity. Right. I just need to get something out of the way. I was covering up information on my screen. So this one is for blood pressure. This is another, and we'll be looking at another racial health disparity here for high blood pressure. So quickly, blood pressure is the amount of pressure that blood puts on the arteries as it flows through them. And the arteries are the blood vessels that take blood away from the heart to the different parts of the body, to our organs throughout the body. And when the pressure of the blood on the arteries is above a certain level, we say that someone has high blood pressure. And what we know is that high blood pressure increases the chances that someone will experience heart disease or have a stroke. So this is a map of New Orleans neighborhoods. And you'll see that there are 3 different neighborhoods that are designated here by arrows and the numbers 1, 2, and 3. So these groups, each of these neighborhoods has a similar median income, meaning that generally speaking, the income in these 3 neighborhoods is about the same. So what they differ on, how they're different, is on the racial composition, the racial makeup of these neighborhoods. In Area 1, which is at the bottom left of the screen, is in Uptown New Orleans, which is between, for those of you who are here in Louisiana, in New Orleans, it's between Napoleon and Jefferson Avenues, and it's on the riverside of Britannia. So in this area, 90% of the residents are white, only 5% are Black or African American. And as you can see at the bottom of the screen where it says percent of residents with high blood pressure, 24% of the residents in this neighborhood have high blood pressure. So then moving to the top of your screen is the Lake Terrace neighborhood. This neighborhood has 61% of its residents who are white, about 26% who are Black, and as you can see at the bottom, 29% of the residents in this neighborhood have high blood pressure. And then finally, Area 3, which is in New Orleans East, this has the highest percentage of Black residents. 71% of the residents in this neighborhood are Black or African American. And this is in the area, for those of you who are local, between Reed Boulevard and Bullard Avenue, and it's near Lake Forest Boulevard. So 71% of the residents here are Black or African American, and only about 1% are white. But what you'll notice is that the percent of high blood pressure in this neighborhood is 40%, which is considerably higher than the 24% and the 29% that you see in the other two neighborhoods that are represented. So this is an example of a racial health disparity. Okay. Oops, sorry, I'm going in the wrong direction here. Okay, so I want to say, let me go back here first, but I just want to say that I just talked about two examples of racial health disparities, but I want to point out that disparities can exist for groups on many different factors, not just race and ethnicity. Health disparities can exist for different groups based on things such as their income, their level of education, sexual orientation or gender, their disability status, and even where they live, their zip code, or whether they're rural or urban. Those types of things can, we see disparities when we start breaking down groups into those different categories. So what causes health disparities like these to exist? And before we answer that question, I want us to take a look at the main factors, the 5 main factors that contribute to health. So the first is individual health behaviors. These would be things like diet and exercise, smoking, drinking alcohol, and maintaining a healthy body weight. Second would be healthcare, the healthcare that people receive. This could be things like getting good quality medical care when it's needed, being able to see a doctor whenever it's needed, as well as getting preventive care such as immunizations, blood pressure checks, diabetes and cholesterol tests, and cancer screenings like mammograms. The third factor is our genes and biology. So genes are made up of DNA, and DNA is the building block of the genes that we inherit from our parents. And these genes, there are certain genes that we can inherit that give us a greater chance of developing a particular health problem. But just because an individual inherits those genes from their parents doesn't necessarily mean that they will end up with that health problem. If they engage in certain good health habits like a healthy diet and not smoking and getting enough physical activity, it may actually reduce their chances of these genes actually showing up in this health problem developing. And also, we talk about biology, and this gets into aging. We know that people tend to develop more health problems as they get older. And we know that there are biological changes that people experience as they get older that can affect their health. So the fourth factor is conditions within the physical environment. And when we talk about the physical environment, this is probably the broadest area of factors. We're talking about several different things here. We can be talking about the safety of the water that people drink and the air that they breathe. We can also talk about the condition of the homes that they live in. And for example, here in New Orleans, we have a lot of old homes that have lead paint in them. And we know that lead paint can have negative health effects. It can be breathed in, it can be inhaled, it can also be eaten. We know that sometimes young children will eat paint chips, and this can contribute to some serious developmental health problems for children, especially. When we talk about the physical environment, we can also talk about the access that people have to healthy foods, being able to be in close proximity, to live close enough to a store where they can buy fresh foods, as well as the availability of safe places like parks where they can get exercise and play. And another important element is the availability of affordable and efficient transportation, which will allow residents to get to the grocery store, to school, to work, and to the doctor's office. And the fifth and final of the main factors that affect health are social and economic conditions. Things like education, income, neighborhood safety, how much crime and violence there is in a neighborhood or a community, as well as employment, and not just employment, but employment where there are jobs that make it possible for people to actually be able to purchase the basic needs of life, such as food and housing, so that they're not struggling to be able to purchase these basic needs. These are all key social and economic factors that can affect health. So now let's look at how much each of these factors is believed to affect our health. So this circle graph, also called a pie chart, and it's called a pie chart because it has slices just like a pie. We can see that each of the slices is a different color, and they're all different sizes. Each one of those slices represents one of those 5 health factors. The larger the slice, the more that health factor affects our health. And as you can see here, the largest slices are the dark blue one, which represents social and economic factors. And then that's followed by the red slice, which represents individual health behaviors. So this tells us that social and economic factors play the biggest role in affecting our health, things like income and education in particular. The amount of education that we have can influence how much income we make, and the amount of income that we make then determines where we can afford to live, and whether we can afford to buy healthy foods, whether we can afford to go to the doctor when we need to, and whether we can buy medicines that are needed to keep us healthy or to prevent disease. Education and income can also play a big role in our individual health behaviors. When people have lower incomes, or they live in areas where it's difficult to access healthy foods and to engage in healthy behaviors, or where there may be unsafe housing, there's less time for physical activity and fewer places where they can exercise safely. These things are all linked to an individual's income, or can be all linked to an individual's income. There's also an extreme stress that people can experience, and this is called chronic stress, that can be felt day in and day out by people who struggle financially. This extreme mental stress can also be caused by negative experiences and difficult situations, such as discrimination, trauma, abuse, living in an unsafe neighborhood, and other situations or issues that a person may experience over a period of time that they don't really have any control over. We know that this type of chronic stress can cause many health problems, and sometimes to cope with the stress that people are feeling, they may turn to behaviors such as smoking cigarettes and drinking alcohol or using drugs, which can also have negative health consequences. So these are just some of the many ways that social and economic factors can impact our health. So I have one last example of a health disparity that I want to show, and this is again using high blood pressure. But this disparity is going to be based around income as opposed to race, because the 4 neighborhoods that I have outlined here, or have indicated here, are all predominantly Black neighborhoods here in New Orleans. They differ, however, on the median income, and this tells us that folks in these different areas, that in area 1, for instance, which is in our Central City neighborhood, has the lowest income of the 4 at $12,000 a year. That's about what, in terms of the middle, about half the people that live in that neighborhood make this amount of money a year. So second neighborhood is in the lower 9th ward, which you can see that the income has gone up about $7,000. Then we jump up to the top of our screen at the Little Woods neighborhood in New Orleans East, area 3, where the median income is $32,000. And then finally, the Reed Boulevard West area, which is there between Lake Forest Boulevard and Chef Highway, for those of you who are local around Reed Boulevard, where the income is at about $42,000 a year. And what you're seeing then at the bottom of the screen is that as the income increases, the percentage of residents in those areas with high blood pressure decreases. Okay, so you have higher blood pressure, higher blood pressure, excuse me, in the lowest income residential neighborhood and the lowest high blood pressure or percentage of high blood pressure in the area where the income is the highest. So that is a disparity based on income. So getting back to the question, why do health disparities exist? Well, disparities exist because not everyone has the same opportunities to live healthy and make healthy choices. Education and income, as I discussed, determine whether people have access to the things that can help them to be healthy. So people with more education and higher incomes typically have better access to the things that lead to good health, whereas people with less education and lower incomes often find it difficult to get access to these things. And ideally, all people, regardless of what their education or income is, would have the same opportunities to make healthy choices and do those things and engage in those things that would allow them to be healthy. And if there were no barriers to good health, then most of the health disparities that we see would not exist. So really what we're saying is that health disparities are avoidable and don't really need to happen. So with a picture of our beautiful city and the crescent in the Mississippi River as my last slide, I hope that what I've shared with you has helped you to gain an understanding of what a health disparity is, what causes health disparities, and what some of the disparities are that exist right here in the New Orleans community.
Great. Thank you so much, Dr. Broussard. That was a great foundation and a lot of good information kind of to let us know what disparities are, what they look like here in New Orleans. So I'm going to now pass it over to Dr. Miele, who is going to continue. Dr. Miele?
Thank you. Hang on, I'm about to share my screen. And thank you, Dr. Broussard, for this beautiful presentation, which very nicely segues into mine. Hang on, I'm probably sharing the wrong screen. All right, can you all see this?
Yes, I can. I think we're good.
So it's almost impossible to turn on the TV, radio, or go online today without hearing something about COVID-19. New Orleans has suffered tremendously and continues to suffer through this pandemic, and I've been personally involved in our response to it. Unfortunately, there is a significant health disparity in how we're being affected by COVID-19, and this is actually a poster child for the importance of what we call precision medicine. Now, one of the most striking features of COVID-19 disease, the disease caused by SARS-CoV-2 virus, is that it looks very different in different people. Some people have no symptoms at all, which doesn't mean they cannot infect others, and it doesn't mean they're not going to have long-term damage. Some people have mild flu-like symptoms, but some people get into real trouble. They have trouble breathing, and they can die from bleeding in their brains, bleeding in their lungs, failure of their kidneys, failure of their liver, heart attacks, and strokes. Even when they do survive, there are chronic consequences of a severe case of COVID-19. Different people have completely different presentations. I've personally seen couples where one of the spouses was in the hospital and the other one barely knew they had it, and they both had it. So why is this so variable? Can we tell who's going to get a bad case? Yes, but it's not easy because this variability in the symptoms can be affected by a lot of things. It can be affected by our own genetics, how we differ from one another, by the environment, where we live, and how much money we have. As you've heard from the previous presentation, that affects our access to things that keep us healthy, and our lifestyles. This is from yesterday. This is from the Louisiana Department of Health. As you can see here, this is how deaths in Louisiana from COVID-19 break down by race and ethnicity. 47% of the individuals who died are African American, but the population is not 47% African American, indicating that African Americans have a larger likelihood of dying of COVID-19. Average age is 75 years old. We were hearing from other countries that males were much more likely to die than females. That is really not entirely, I mean, they're a little bit more likely to die, but not as much as we've seen in other countries. But look at this. You heard from Dr. Broussard's presentation that there are a number of diseases where we have clear health disparities, and these include high blood pressure, hypertension, heart failure, obesity, diabetes. Look at what the most common disease that is associated with severe deadly COVID-19 is. It's high blood pressure. It's very well established that if somebody has high blood pressure, they're more likely to die of COVID-19. This is because the virus attacks the inside of blood vessels. And if our blood vessels are under strain already from a lifetime of high blood pressure, it's easier for the virus to damage them. Now, high blood pressure can cause kidney disease. It can cause heart disease, and it can cause strokes. And all of these things are seen very clearly as associated with mortality from COVID-19. The risk factors that we know of are high blood pressure, diabetes, obesity, chronic kidney disease, age over 65, but there are many others that we don't quite understand. There are people in their 30s, 20s, teen, or children who die of COVID-19, and it's impossible to tell whether somebody is going to have a severe disease or not, simply looking at their age. So don't think for a moment that just because somebody is young, they're immune. We just don't know who is going to have a more severe disease. So we said that there are factors in the environment, lifestyle, and genetics that can affect how severe a COVID-19 we can get. Well, as you heard before from Dr. Broussard's presentation, unequal access to quality food, healthcare, and testing are health disparities. For example, we just said high blood pressure is a risk factor. If you eat salty food, that increases your blood pressure, that increases your likelihood of getting a severe disease. Also, another disparity is some of us have the privilege of working from home. Not everybody can. Essential workers have to go to work. That includes us, healthcare providers, but it also includes people in many other professions, in the hospitality industry, in essential services, first responders. They have to go to work. Being in those professions is a risk. We tested first responders in New Orleans in my laboratory, and we had a fairly high rate of positivity. Over 15% of them were infected. Systemic racism, which in general decreases your likelihood that somebody's going to receive adequate testing, treatment, etc., etc. And multi-generational households. Why am I putting this in here? If grandparents are taking care of grandchildren, it's easier for the grandchildren who may get infected at school to infect their grandparents. If grandparents are living by themselves in a single family dwelling, they can tell the grandkids, sorry guys, don't come visit me. I need to isolate myself. If you don't have that luxury, you're going to be exposed, more likely to be exposed to infection from a child or a young person. Now, I'm going to show you a few very high profile papers that have come out in the last few weeks. One shows very clearly that obesity is a predisposing factor to severe COVID-19. Obesity is a health disparity because in order to not be obese, you need to eat quality food, you need to be able to exercise, you need to have time to exercise, and all of these things cost money. So it's not necessarily a matter of choices, it's a matter of what you can afford to eat, when you can afford to eat, and whether or not you have areas where it's safe to exercise. Genetics. You've heard, I'm sure, in the news that blood groups seem to be associated with more or less severe COVID-19. It isn't necessarily exactly blood groups, but in the place in the human chromosomes where the genes that control blood groups are, there's a whole bunch of other genes that may be associated with risk of severe COVID-19. Now, this is being verified now by a large study that's led by the National Institutes of Health. This is individual variability. It's not group variability. Each of us has a different group of genes that control blood type. For example, I have A and B. So it's not necessarily these genes themselves, but it may be their neighbors on chromosome 9 that control the risk. More genetics. This is really important. The group of, we're all different from one another, each and every individual. The genes whereby we are most different from one another are the ones that control our immune systems. If you look at how variable chunks of the human genome are, the parts that are most variable between individuals are the ones that control how we respond to infectious agents. That makes sense, if you will, because we needed to survive our evolution, and we've been around in the present form for about 90,000 years. There are many different combinations of immune genes that have helped us survive. For example, the genes that control my immune system come from East Africa. They're in chromosome 6, and they've been around for 200,000 years. My sister has a different group of genes in that same place. So individuals are very, very, very different in the genes that control how well they respond to infectious agents. We don't need to go into the details of how these genes control our response to infectious agents, but even two siblings can be completely different from this standpoint. Now, this is a combination of environment and genetics. We've had a very surprising finding this month, well, last month in August, that some people seem to have pre-existing immunological memory of COVID-19, even though the virus was not in the human population. These people are less likely to have a severe disease. Why could this be? Well, there are other coronaviruses that sort of look like SARS-CoV-2. Some people, just because of their immune genes, may be more likely to have a response that cross-reacts, that is capable of recognizing the new virus as well. But it also depends on, they have to have been exposed to the other coronaviruses to develop a response. And so it's a combination of what our immune systems can do and what they've been exposed to, which is a function of what environment we live in. And finally, this is something that's not necessarily recognized. There's a whole bunch of medications that can affect your risk of developing severe COVID-19. This is a story that's a cautionary tale. In the beginning of the pandemic, based on a little bit of information, doctors said, okay, people who are taking these particular classes of high blood pressure medications, ACE inhibitors and angiotensin receptor blockers, need to discontinue them, because the target of these medications is is also the target where the virus binds. And a call went out that this was extremely dangerous to take these medications. It turns out that is not true at all. In fact, if anything, these medications are protected because they actually compete with the virus. This also brings to light something that you all need to keep in mind. If you had told me my birthday, March 13th, that I would be spending the next 5 months working on a virus, I would have told you, nah. So all of this is really new information, and the science is evolving very rapidly. I know it's confusing. It's our job to keep you up to date with the latest developments. Now, this actually made me very happy because I happen to be on these medications. I have high blood pressure and I take an ARB. So I was quite happy to see from big data analysis that people who take these medications are actually a slightly lower risk, but not higher risk as we anticipated initially. Again, look at the date of this publication. August 2020, all the stuff is coming out fast and furious. Researchers all over the world are really working very hard to figure this out. And let's not forget that the virus is changing in time. You may have heard a few news pieces about this. This is a graph that I generated myself. The colors indicate different strains of virus. It started out in China as 19A, and look at what happens. As time goes on, 19A became 19B, then 20C, then 20B. So most of the people in the United States right now have these yellow viruses that are not the same ones that developed in China last winter. And they're biologically different, which, by the way, explains why some people can get infected twice. If somebody got infected early on with blue virus here, they developed a little bit of immunity to blue virus, but then 6 months later, they find yellow virus. They may not necessarily be completely immune. So all this is a poster child for precision medicine because there is enormous variability in the patients, in the risk factors, and the cause of disease itself. So I'm going to give a quick shout out to precision medicine. The definition of it is that it's an approach for disease treatment and prevention that takes into account individual variability in lifestyle, environment, and biology. So it looks at every person as an individual as opposed to one size fits all. And boy, does this apply to COVID-19. So these are all the things that I just told you earlier that can affect the outcome. Demographics, social determinants of health, comorbidity, drug exposures, previous exposure, viral genetics, individual genetics, all these things are taken into account in precision medicine. You'll hear on the third day a lot more about all of us. It just suffices to say that it's a program that aims to enroll 1 or more million participants that reflect the diversity of Americans, but there's opportunity for participants not only to provide data, but to participate in research as well, and to get information back from the program. This is one of the products of it. It's a database that collects data on COVID-19 from a lot of institutions that anybody can mine, not just universities, even citizen scientists can mine through an appropriate process of vetting. We need to make sure that people are going to make ethical use of this data. Both LSU and Tulane are participating in all of us. Each of us has enrolled about 1,500 participants, so there are over 3,000 New Orleanians who've already signed up for this through our two universities. And we had to stop enrolling because of COVID-19. We're hoping to start enrolling again soon. Now, the data portal for all of us is open to the public in beta version, and there's already data in there from over 300,000 people who have enrolled. This is open to investigators, but also citizen scientists. This is from this morning. It's the blog by the NIH director, Dr. Collins. There is a group. This is a spontaneous group formed by citizens who happen to have had COVID-19. This is the website right here, who have organized themselves to describe their long-term symptoms. As you know, you've probably read in the media that some people who have COVID-19 experience long-term symptoms. What are these symptoms? The best people to ask are the patients themselves. And so this group has organized itself to collect statistics between different patients all over the country, as well as Canada and the UK, on how they feel weeks or months after having COVID-19. And this has produced insights that were so important that the NIH director thought it necessary to highlight it in his blog this morning. I added this slide because it was ideal for this talk. It shows how we can all be participants in research, not just enrollees. This is actually the pre-COVID team. If the next picture is going to include Aisha Umrigar, who's part of this call, but we're all going to be wearing masks. So I don't want you to get the idea that we took masks off to take this picture. This picture was taken in February. If we had taken it now, we would all be wearing masks. I'm going to thank you for your attention and be happy to take any questions.
Thank you so much, Dr. Miele. Do you have one question in the chat from Tamara, who was asking about changes in the COVID virus, and she was asking how those changes occur and what can cause the changes.
Oh, that's a wonderful question. So the virus has a genome that's made up of RNA. RNA is more fragile than DNA, and it's easy for it to be damaged. Now, in each of us, when we're infected, there are billions of viruses that form on a daily basis. And as it replicates itself, the virus can make mistakes. These mistakes are mutations that change the genes of the virus. If by chance one of these genes changes in a way that makes the virus more likely to survive, that mutation is going to be propagated better. And so this is how yellow virus took over from blue virus. It's because it's better at spreading due to a random mutation. Now, this is the scary thing. The only antiviral that's FDA approved to treat COVID-19 is remdesivir. Remdesivir works by increasing the number of mistakes in the replication of the virus. Too many mistakes, the virus dies. but not enough mistakes to make better mutants. So this is the exact same thing that happened with HIV. That's why we're now using cocktails of medications for HIV, because the original drug that was approved for it, AZT, actually increased the mutations in the virus. And if one mutation hits the jackpot, you're in trouble. In particular, this is something that the biggest switch that the virus made was, it happened in Germany. It came from China. When it got to Germany, it acquired randomly a mutation that makes the spike. The spike is those little things that stick out of the, you've all seen pictures of the coronavirus. It looks like a landmine. It's got these things that stick out of it. Those things are called spikes. And that's how the virus binds to human cells. Now, the spikes in the original virus are pretty fragile. They fall apart. It fixed itself. It found a mutation that makes the spike more stable, and it's 10 times more infectious. That's evolution in real time. And all RNA viruses do that. Influenza, the flu, is an RNA virus, and it mutates fast enough that there's a new one every year. This doesn't mutate quite as fast as the flu, but it does mutate, as you have seen.
There are a couple of questions as well about how these mutations will affect the development of a safe and effective vaccine.
So that's one of my favorite questions. In another lifetime, I actually worked at the Food and Drug Administration, the Center for Biologics, that regulates things like vaccines. I have a favorite vaccine. I don't want to say which one it is because I don't want to endorse any commercial entity. But you need to have a vaccine that contains enough chunks of the virus that even if one chunk changes, you're still going to get immunity to the other ones. If the virus mutates fast enough, we're going to have to change the vaccine like we do for the flu, either every year or every few years. We're going to have to see who wins the race. And the virus is not sitting around. It's changing. So it's going to be a race against time, vaccine versus virus. That's why the next step in testing is going to be not only determining whether the virus is there or not, but actually getting the full sequence of the virus, which we're getting set up to do. That'll tell us how fast it's changing right here in New Orleans.
I actually have a question that's maybe a bit more philosophical, and it's for both you, Dr. Miele, and you, Dr. Broussard, as well, if you want to chime in. Just, you know, I think with what we're seeing with COVID, a lot of these health disparities that we know exist and have known about for a long time are really being brought into this kind of harsh light. Do either of you have any thoughts as to what maybe that could mean for health disparities and maybe these kind of systemic issues or policies down the line, even if it's just kind of like what you hope? I think that right now everyone's feeling obviously very discouraged and worried, and I think maybe one good thing to come out of this could be some shifted focus on these health disparities. So I don't know if either of you have any thoughts about that.
I actually agree with that. If there is a teeny tiny bit silver lining, and I've been working on health disparities in the cancer field for 20 years. And in the field, everybody goes, oh yeah, there's horrible health disparities in this cancer, that cancer, the other cancer, but that doesn't really come out in the general news media as it is among us. This is putting health disparities on the radar screen. And if there's a tiny silver lining, it is that we cannot deny that these things happen and that we need to fix them. You know, when you have a disease that kills 200,000, almost 200,000 people in few months, and you see that it kills people differently depending on things that are not under their control, you have to acknowledge it.
Dr. Broussard, do you want to add anything to that?
I absolutely agree. And I just feel like we have to hold our leadership accountable and make them not let this get swept under the rug, like so many issues ultimately do become swept under the rug, but not let this fall off of the radar and hold our leadership accountable. We need to take what we're seeing in real time right now, to use Dr. Miele's phrase, and apply that to the other chronic diseases that we see, that we've known for a long time now, that their disparities exist. And we just kind of say, yes, they exist, and we throw out some research dollars to do research, but we don't really see any needles moving very far. So hopefully this will be a critical moment and opportunity for us to really make some change, not just in terms of this particular infectious disease, but across the board with chronic diseases as well.
I feel the same. There was one question that I missed that I think will go to you, Dr. Miele, but it's do you have any comments on the recent report of a vaccine that will be available on November 1st, 2020?
I'm skeptical. And here's why I'm skeptical. Again, as a former FDA reviewer, a vaccine is something that is given to millions or even hundreds of millions of people. That means that if it has side effects, even uncommon ones, they are going to happen. If you have a side effect that only happens in 1 person out of 1,000, but you give the vaccine to 1 million people, you're likely to see 1,000 people affected by that side effect. Our confidence in a vaccine program depends on it having been rigorously reviewed for safety and efficacy. I am all in favor of vaccines. I am waiting for one. I want to get one tomorrow morning if I can, but it needs to be studied scientifically. It cannot be driven by considerations that have nothing to do with science. It takes time. The first phase 3 clinical trial of vaccine XYZ plans to enroll 30,000 individuals. That's the right size for that vaccine, for that trial. Well, it started enrolling a couple of weeks ago. These 30,000 people need to be vaccinated and then followed in time for side effects and for efficacy. That itself is going to take 6 or 7 months. It's September. I mean, normally the development of a vaccine takes 10 years. We're trying to do it in 2, and that itself would be extraordinary. 1.5 would be record-breaking. 2 months, that's just not feasible.
Unfortunately. I have another question here from Lori, who asks, do we know if the medication prednisone is implicated in worse COVID cases or a poor outcome from the virus?
Actually, the opposite. Reports now show that steroids, including hydrocortisone, dexamethasone, prednisone is a steroid, improve outcomes. Again, initially, it was feared that they would worsen it based on the notion that they can reduce the immune response. Well, it turns out that the massive immune response triggered by a virus that our bodies are not used to is what does the most damage. So, as a matter of fact, the best news that I have this week about COVID-19 is that steroids are effective in reducing the severity of disease in hospitalized patients. Why is it the best news? Because these drugs are all off patent, they're cheap, and they're already out there. So dexamethasone has been around since I went to medical school, and I graduated in 1981. So, we already know what they do. They've been used in millions of people, and they're possibly the most useful addition to our to our treatment arsenal since we started looking into this disease.
There we go, I was muted. So that's all the questions I see. I did put a link to a survey in the chat, so if you all have time, please feel free to fill that out. It'll just take a minute. We are meeting at the same time next week where we're going to talk a little bit more about health research around COVID, around health disparities. So please feel free to join us next week. It's the same registration link as you used for today's program, so you're already registered. And thank you, Drs. Broussard and Dr. Miele, for joining us today and giving us such great information. I really appreciate it.
It's a real
You're
pleasure.
very welcome. My pleasure.
All right, thank you. Thanks, everyone.